Hello everyone and welcome to Chapter 5, the Peripheral Nervous System. So this chapter focuses on the anatomy and physiology of the PNS, the Peripheral Nervous System. In Chapter 4, we were sort of concerned about the basic structural plan of the nervous system as a whole, and then we talked about the neuron and the central nervous system, the CNS. Now, remember that the nervous system is divided into the central nervous system, which is the brain, spinal cord, and their coverings, and the peripheral nervous system, which is the cranial nerves, the spinal nerves, and the ganglia. Now, the PNS has two main subdivisions, the somatic subdivision, which monitors and controls bones, muscles, soft tissues, and skin, and the visceral, or the autonomic subdivision, which is associated with the internal glands, organs, your viscera, blood vessels, and mucous membranes. Now, the autonomic nervous system, the ANS, is also divided into three more subdivisions, depending on the source. Some say two. This textbook tells you all three. There's the sympathetic aspect of the ANS, which activates arousal responses and expends body resources to respond to emergency situations or any physical activity that your body requires. So this is considered the fight or flight response system. Your book calls it the flight, fight, fear system. But any highly emotional state, such as joy, excitement, elation, all these are sympathetic in nature and are part of this autonomic nervous system. The parasympathetic aspect of the autonomic nervous system reverses the response of the sympathetic system by returning the body to a non-alarm state and restoring body resources. Oh, homeostasis surfaces again. You can think of these functions of the parasympathetic aspect as rest and digest. The parasympathetic nervous system is associated with relaxation. You want to trigger the parasympathetic nervous system during massage. You want to relax. The enteric nervous system, which directly controls the gastrointestinal system and interacts with the vagus nerve, is the third portion of your ANS. All right, so let's review. What is a nerve? A nerve is a bundle of axons, dendrites, or both. Now, remember from both Chapter 2, an intro to anatomy, and in Chapter 4 from last week, that sensory peripheral nerves transmit information to the CNS. They are afferent with an A nerves. Afferent peripheral nerves transmit information to the central nervous system. They are coming from outside stimuli and taking it back to the brain and spinal cord. They're giving it a message from the outside. Now, the motor peripheral nerves carry impulses from the brain back to the body. The efferent, with an E, peripheral nerves carry the information from the brain back out to the rest of the body. Okay, so what are cranial nerves? Cranial nerves enter or leave the olfactory bulbs, thalamus, visual cortex, and the brainstem. If they enter, they are the sensory nerves. If they leave, it is the motor nerves. Remember, afferent and efferent. There are 12 pairs of cranial nerves. Disorders of the cranial nerves can result from a stroke, a tumor, or trauma. And a lack of function may indicate damage to a particular nerve. The resulting change in action may help locate the lesion or area of damage. For example, the accessory nerve, which is cranial nerve number 11, affects the trapezius and sternocleidomastoid muscles. Dysfunction in either of these muscles may indicate involvement of those nerves. So you damage the nerve, the associated muscles or functions will be impaired. You do have cranial nerve assignments to cover that are in your chapter's work for this week. So I'm not going to cover all 12 of those in great detail, but please do pay attention to those. They are also in your PowerPoint. The other thing that needs to be discussed, and I will try to include an extra video in your extra resources for the week, is the vagus nerve. VAGUS, not Vegas as in Las Vegas. The vagus nerve deserves a ton of discussion because evidence indicates that massage directly affects vagal function. The connections between the enteric nervous system and the central nervous system involve the vagus nerve. The vagus nerve is constantly sending updated sensory information about the state of the body's organs to the brain via afferent with an A nerves. Vagus nerve communication between the gut and the brain involves neurotransmitters such as acetylcholine and GABA amino acid. These neurotransmitters lower heart rate, blood pressure, and other functions related to the parasympathetic division of the ANS. If you're ever interested, there is a ton of fascinating research done about GABA amino acid and helping with addiction responses in people who have various opioid and other addictions as well. GABA amino acid is absolutely fascinating stuff. Now, vagal tone is an internal biological process that represents the activity of the vagus nerve. Increasing vagal tone activates the parasympathetic nervous system. Remember the rest and digest part of the system? We want to relax. Massage really helps the parasympathetic nervous system and this vagus nerve. Other vagus nerve effects include reducing inflammation in the body, regulating stress, anxiety, and fear, and partly functioning with memory. Vagus nerve stimulation refers to any technique that stimulates the vagus nerve, including manual or electrical stimulation. The relationship between depression, inflammation, metabolic syndrome, and heart disease might be mediated by the vagus nerve. So your book has a little side blurb about the practical application of massage in the vagus nerve. And it states that the distribution of the vagus nerve affects many visceral functions. Yes, it's part of the enteric system. So massage has been shown to support vagus nerve function, especially in premature babies, resulting in better development such as weight gain and fewer developmental problems. The auricular branch of the vagus nerve, auricular as in ear, supplies sensory innervation to the skin of the ear canal, tragus, and auricle. Massage of the ear may be an effective point of stimulation for the vagus nerve. So not only is this an excellent point to study for reflexology, also in a variety of treatments for the face, head, and neck in terms of massage, but direct stimulation of the ear and ear massage can stimulate the vagus nerve. Chapter 5 also delves into the spinal nerves. Now recall from Chapter 4 that 31 pairs of spinal nerves originate in the spinal cord and emerge from the vertebral column, all right? They branch outwards. They contain sensory and motor fibers in the same nerve, so they are mixed nerves, making sensation and movement possible. They're identified by a letter and a number, which refers to their segment of attachment to the spinal cord. And after the spinal nerves exit the spinal cord, their nerve pathways generally follow the same pathway as the arteries and deep veins of the body. They also flow along many of these meridian channels if you think back to Chapter 1 and 2. Deep lymphatic vessels also follow this pathway. Often they are found all bound together by connective tissue into what is called a neurovascular bundle. This is another reason why we pay attention to fascia and the tightness of fascia, because the fascia is what wraps around them like a tight little Ziploc bag, forming these neurovascular bundles. Our next focus is nerve plexuses, plexi. Most of the spinal nerves, except those that emerge from the 2nd to 12th thoracic vertebral spaces. Except for those, they all converge in small groups to form an intersecting network known as a nerve plexus. Each plexus contains fibers that innervate a specific region of the body. Overlap of nerve function prevents total loss of function if just one nerve in the group is damaged. So your friends make up for it. The 4 major plexuses are the cervical, brachial, lumbar, and sacral plexus. The thoracic nerves are the motor nerves to the intercostal muscles and sensory nerves from the skin of the thorax. So they're all spread out over your chest region, in between your ribs and those intercostal muscles, and throughout the entire thorax. Now, you do have an assignment that goes into depth over all 4 of the nerve plexus, and there are some quiz questions as well as videos and imagery of those. So we won't go into detail about those here in this lecture. But remember, there is the cervical, brachial, lumbar, and sacral plexus. All right, we are touching back over spinal nerve injury again. Injury to a nerve stops the transmission of signals to and from the brain, preventing muscles from working and causing loss of feeling, which we call numbness, in the area supplied by that nerve. Nerves are fragile and can be damaged by pressure, stretching, or cutting. Pressure or stretching injuries can cause fibers carrying the information to break and can interfere with the nerve function without disrupting the insulating cover. When a nerve is completely cut, both the nerve and the myelin sheath are damaged. When the nerve fibers are separated during injury, the distal end of the fiber, which is the one furthest from the brain, completely dies. The proximal end, the one closest to the brain, which contains the cell body of the fiber, does not die, and after some time, it might begin to heal. If the myelin sheath was not cut, the nerve fibers might grow down the empty tubes until reaching the muscle or sensory receptor. However, if both the nerve and sheath have been cut, the growing nerve fibers may grow into a ball at the end of the cut, forming a nerve scar called a neuroma, which is painful and can cause an electrical feeling when touched. Injury to the sensory portion of any spinal nerve causes loss of sensation or altered sensation in the innervated area. Hyperesthesia is excessive sensation, and hypoesthesia is a decreased sensation. Paresthesia is numbness, tingling, and burning sensation in an area, and anesthesia is a complete loss of sensation. We say when you're going into surgery or going under anesthesia, you're going to lose all sensation. You won't feel any sensations of the surgical procedure that you're about to experience. Now, injury to the motor nerves impairs movement or function and results in completely impaired movement, various forms of paralysis of the muscles served by the damaged nerve, or even just gradual weakening and then ultimately wasting away of the muscle, which is called atrophy, and uncontrollable twitching, which is called vesiculations. When upper motor neurons are damaged, the results include spasticity or stiffness of limb muscles, overactivity of the tendon reflexes, and loss of the ability to perform fine movements. When the lower motor neurons are damaged, the result is muscle weakness, twitching, loss of muscle tone, flaccid paralysis, diminished or absent reflexes, and progressive atrophy of the muscle. Now, in our assignments, we're going to go over myotomes and dermatomes. You're also going to touch up on them in your pathology class. If you haven't already had pathology, you will have pathology, and you will see a dermatome exercise during that as well. A myotome indicates the relationship between the spinal nerve and the muscles innervated by it. A dermatome is a section of skin supplied by a single spinal nerve. This chapter also covers reflex mechanisms and types of reflexes, which are in your PowerPoint, and in several of your assignments this week, you will see reflexes popping back up. So keep your eye out for that, and of course, study in your actual chapter itself. And then you're going to see some information about the sensory receptors of the somatic nervous system. Now remember, the somatic nervous system is a division of the peripheral nervous system, and it primarily affects the skin, muscles, joints, and bones. Sounds like it relates to massage therapy. Receptors that detect information from outside of the body are called exteroreceptors and are stimulated by actions or changes in our external environment. Two examples are our eyes and our ears. Changes in our internal environment stimulate the visceroreceptors or internaroreceptors. These receptors receive signals monitoring factors such as blood pressure and hunger. Very specific to the somatic aspect of the PNS are specialized receptors. In and around the muscles and joints of our body are proprioceptors, which are affected by changes in position, movement, and tension. One of my favorite modalities of massage therapy is proprioceptive neuromuscular facilitation. And yes, it involves these specialized muscle and joint proprioceptors that are affected by changes in position, movement, and tension. So I know I've stated it before, if you really want to get into the Eastern theories, concepts of the body and body functions, unfortunately, this textbook is not the place to go. Every single book I have on Asian theory or modalities is well over 1,000 pages by itself. But chapter 5 does have a small blurb here about the Eastern-Western connection, talking about the ANS, the autonomic nervous system. The autonomic nervous system is a clear example of the yin-yang concept. The ganglia of the parasympathetic system tends to occupy the same areas traditionally identified as chakras or energy centers by traditional Indian medicine. The sympathetic chain ganglia follow one of the paths of bladder meridian, which is located on either side of the vertebral column. Specific acupuncture points on this meridian, called backshu points, are considered to be the locations of where the qi of the respective yin or yang organs is assimilated for Chinese medicine. Practitioners use techniques for stimulating these points to relieve dysfunctions of the corresponding organs. One can see a correlation between sympathetic ANS function and these important organ points in the Asian meridian system. Now, it is generally accepted that the traditional meridian system is also connected deeply with the fascia. There are multiple studies on the relationship of fascia to acupuncture points and meridians, and they have found substantial overlap of acupuncture points and meridians to fascial planes within the body. The needle grasp effect found in acupuncture is also related to the fascia. We now know in Western medicine that the fascia is innervated with both somatic and autonomic sensors and receptors. And research over the past 20 years has identified the crucial role that the ANS plays in stress-related disorders. This research has validated the effectiveness of many ancient healing, cultural, and spiritual practices that serve to bring the ANS under voluntary control, facilitating conscious control of homeostatic processes that Western medicine believed to be completely involuntary before. Your book has an awesome mentoring tip right after this that states, whether Western research-based evidence supports the claimed benefits of ancient healing traditions is the subject of debate within the massage therapy community. I mean, Eastern medicine concepts and cultural concepts have been around for thousands of years, whereas we know Western medicine is only recently catching up to massage. And massage is still considered in many Western areas to be a woo-woo practice and not necessarily scientific, right? So evidence-informed practices is really important in Western medicine. Massage is relatively new. It's only been accepted for a couple of 100 years in Western medicine. So this evidence-informed practice is an important concept in massage therapy. However, technology may not yet be sophisticated enough to unravel the mysteries of some ancient and cultural forms of healing. This doesn't mean that they're not factual or correct. It means that our scientific equipment and our ability to do clinical research studies on the human body and the effects of these practices of various forms of bodywork and massage practice are not able to be measured yet. Our instruments are not yet sophisticated enough, but that doesn't mean that the effects are not real. Regardless, research continues to reinforce the benefit of including these traditional healing practices in integrated medicine. Integrated medicine, meaning both Western and Eastern concepts, are put together to be at use to the client. According to Western scientific theory, massage therapy does not have enough evidence to be considered evidence-based practice, but the research quantity and quality is improving. The importance of biologically plausible claims was discussed in previous chapters, and I have also put out the Miami Touch Institute clinical studies for you guys to observe. I cannot recommend looking up clinical studies like these enough. They will definitely help you have evidence-based clinical studies to use as an argument for your massage therapy practice. Division based on either or regarding healthcare does not serve the growth of the massage profession. Cooperation and ongoing research should close the divide in the future between Eastern and Western medicine. Massage therapy is rooted in compassion and kindness for the client. It is important to remember this when ambiguity exists. Your book has a pretty awesome table in it, table 5.4 in chapter 5, and it shows the sympathetic and parasympathetic effects on the structures and systems of the body. So in the left-hand column, it has all of the structures and systems. In the middle column, it's the parasympathetic system response. And on the right-hand side column, it is the sympathetic system response. So we'll take the eye, for example, and we'll talk about the tear glands. The parasympathetic system response is secretion, but there's no response in the sympathetic system. In the skin, there are sweat glands. There are no responses in the parasympathetic system. However, in the sympathetic system, there is secretion that becomes increased by this. It goes through the eyes, the skin, the cardiovascular, digestive, urinary, and respiratory systems. For some reason, mental activity is in the respiratory system. I find that interesting. And in the parasympathetic system response, we see calmness. Massage activates the parasympathetic system response. Remember, rest and digest. So for mental activity, the parasympathetic system response is to calm down. The sympathetic system response, remember, is flight, fight, fear kind of stuff. So your alertness is increased for your mental activity in the sympathetic system response. Chapter 5 also covers our senses, our many senses. There's the vestibular sense, which is balance. Thermal sense, which is the scent of heat and the absence of heat. Kinesthetic sense, which provides the brain with information on the relative positions on the parts of the body during movement. Where are you in the space around you? Pain sense, directional sense, and internal sense are all also part of this. It is above and beyond the basic 5 senses that you learned about in school. Now, of course, those are important too. Let's talk about the sense of touch. Touch, or mechanoreception, results from activation of neural receptors, generally in the skin, including the hair follicles, but also in the tongue, throat, and mucous membranes. Are you in front of your computer right now? Look at your keyboard. How would it feel on your tongue if you licked your keyboard? How would it feel if you licked your doorknob or the door frame? I bet your tongue knows exactly how it would feel to lick everything. If you actually did it and physically felt it, that would be mechanoreception. But you already felt it in your brain because your mind makes up your sense of reality. Don't forget that. All right, your sense of hearing. Sounds or vibrations created by mechanical methods that are turned into recognizable patterns of electrical energy in our nervous system. These vibrations can travel through the air, water, or solid surfaces, and the brain can recognize an incredible amount of variations in pitch, volume, and tone. When these sounds reach the ear, they are transferred to the hair cells in the ear, and the lower frequency signals are given priority when transmitted as electrical signals to the brain. Thus, a slow, deep, even voice is the best one to use when we really want to be heard. Now, along with the ear is your vestibular system, which maintains the body's balance and equilibrium. Only the inner ear functions in the vestibular system. The inner ear consists of a group of fluid-filled tubes that run through the temporal bone of the skull. In this region of the inner ear, fluid-filled circular ducts are positioned at right angles to each other, and each duct contains hair cells embedded into a gelatinous substance. This sounds like a horror movie. These specialized receptor cells respond to vibrations and motion. These semicircular canals are 3 loops of fluid-filled tubes that are attached to the cochlea in the inner ear. All right. This is where your sense of balance comes from. If this vestibular balance mechanism is disrupted, the result is often vertigo, where you feel extremely dizzy, or balance problems. If it goes undetected, I don't know how, or untreated, the sensory information can contribute to anxiety and complete panic disorders. Your sense of sight. Vision. We're back to more fluids. The eyeball is a fluid-filled sphere. Unless you're my husband with extreme eyeball problems and it's shaped like a massive football that's about to explode. All right. It is 3 layers of tissue wrapped around fluid. The outer layer comprises of the sclera and the cornea. The sclera is your white fibrous structure that maintains the shape of the eye and protects the inner structures. The cornea is the clear portion in the front that allows the light to enter the eye. The optic nerve is created from association neurons in the retina, and the point where the nerve exits the eye is called the optic disc or the blind spot because it has no photoreceptors in the back of the eye. Now, please study page 169 for the shape of the eye. Of course, the eye is in a couple of your assignments this week, or at least in one quiz. It is also in your PowerPoint. It is not necessarily extremely important for massage therapy that you know every single part of the eye, but vision, visual acuity, and of course disorders that can be accompanied with dysfunction of the sense of sight are important to massage therapy. So please pay attention to chapter 5 on that and your associated assignments. Of course, you also have the sense of taste, which is one of the more complex senses. There are specific areas that everyone has corresponded to: sweet, sour, salty, and bitter taste, although they are finding now that the nerves actually are sort of all entangled. You should have a video on that in one of your quizzes this week. There's also the sense of smell. The sense of smell, according to your book, is a primitive sense that does not translate well to the methods of human communication. For our ancestors, smell was a main life-saving sense. And of course, smell still alerts us to danger, but it deals with our unconscious animal-like behaviors and experiences and elicits gut-level emotions. This is something to keep in mind with people that have PTSD. Something as simple as a candle going out and the burning smoke smell can trigger someone with PTSD that is associated with a fire. Their house burned down and killed family members, or they were involved in a violent scenario that involved smoke or fire. So things that seem very small, innocuous, just remember these things can be triggered. Some people have extreme allergies. The sense of smell will trigger instant headaches if someone's allergic to lavender and you have a lavender mist in your office, or your previous client wanted a heavily scented lavender oil used on them. That might trigger your next client with their sense of smell. So that is absolutely something to take into consideration for sure. Now, your sense of smell, like your other senses, are covered in one of your weekly assignments and in your PowerPoint, so just please be aware of that. Chapter 5 also has pathological conditions of the PNS, such as compression syndrome, entrapment neuropathies, and nerve impingement, also known as a pinched nerve. These are usually all characterized by pain or a loss of function of the nerves, both sensory nerves and motor nerves, as a result of chronic compression. Tissues that can bind and impinge on the nerves are the skin, fascia, muscles, ligaments, and bones. I'm just going to say it again, fascia. The most common type of injury to a nerve is an impingement or pinching of the nerves. This can be called a trapped nerve or nerve entrapment. They can become stuck to surrounding soft tissues. That's what a nerve entrapment is. They get bound up inside of a muscle or a ligament or fascia. This is where we talk about things like piriformis syndrome you may hear in the future. You definitely have it in an assignment. Regardless of the cause of the nerve becoming squeezed or pinched, either by a joint pressing on it, part of the vertebrae pressing on it, having it bound to something within the body, the symptoms are all similar. The therapeutic intervention really depends on how the nerve has become entrapped or pinched, though. Shortened muscles and connective tissue, your fascia, often impinge on major and minor nerves, causing discomfort. And because of the structural arrangement of the body, these impingements all really mostly occur at major nerve plexuses, all right? The specific nerve root, trunk, or division affected determines the condition producing disorders such as thoracic outlet syndrome, sciatica, like piriformis syndrome, and carpal tunnel syndrome, which is a part of the median nerve being affected. Now, there are some really awesome nerve stretches that you can do to help with these, but if they are being compressed because of the outward compartment, those muscles around them are impinging upon them, then you need to work on the outlying muscles around that nerve to relax them, to allow them to release that nerve a little bit. So we really need to understand what is affecting our client, how that nerve is being impinged, to really understand what the most effective part of therapy is. And usually they will discover this through their primary healthcare physician with some type of visual testing, such as an X-ray or a CT scan, or most likely the most beneficial one would be an MRI, to show where these impingements are actually happening and how they are happening to your client. So if we're talking about impingement in the brachial plexus, which is situated partially in the neck and partially in the axilla or your armpit region, it consists of virtually all of the nerves that innervate the upper limb. So if you have an imbalance in the brachial plexus that increases pressure on it, It can result in pain in the shoulder, the chest, the arm, the wrist, the hand. You could have a compression issue up there that mimics carpal tunnel syndrome. I have heard many anecdotal stories of people receiving surgery for carpal tunnel syndrome, which only created scarring in that area, causing actual carpal tunnel syndrome, but it was never actually fixed by the surgery because they actually had compression in the brachial plexus and not carpal tunnel syndrome at all. Scary stuff. Carpal tunnel syndrome is usually caused by a compression of the median nerve as it passes under the transverse carpal ligament at the palmar aspect of the wrist. All right, impingement on the lumbar plexus gives rise to low back discomfort. There's usually a belt-like distribution of pain in the lower abdomen, genitals, thigh, and medial lower leg, like a massive swath, like someone has just wrapped a foot-wide towel around the entire body in that area. They can have pain and discomfort in that entire banded region. The main muscles that impinge on the lower plexus are the quadratus lumborum, your QL, and the psoas muscles can really pull on that lumbar plexus. Shortening of the lumbar dorsal fascia exaggerates a lordosis and can cause vertebral impingement on the lumbar plexus. Now, this is someone that looks like they have their lower back arched towards the front of their body. It is curved dramatically. You usually see this in pregnant women, especially those that are carrying twins, people with very large stomachs or large hernias that are forcing them forward. It pulls their back forward. And as that fascia continues to shorten and tighten, it just exacerbates the problem. This is something that we can refer to as a positive feedback loop in this particular case. Now, the sacral plexus has about a dozen different named branches, and about half of these serve the buttocks and the lower limb, meaning the lower portion of your leg and your leg itself. Some of them actually innervate pelvic structures. So depending on where you have pressure on the sacral plexus, it can cause a pain in your butt, in your leg, in your genitals, or in your foot. And they could all be coming from the same area that's actually in your sacrum, but it's affecting you all the way down to your foot. Nerves are fun. Your assignments this week will go into disc herniation, spondylolisthesis, which is a slippage of the vertebrae. It often goes along with extreme hyperlordosis. Lordosis and kyphosis are also covered. There is nerve root compression that you need to be aware of. And there are a few diseases that will affect nerves. One is a cranial nerve condition called Bell's palsy that you will read about. Of course, herpes, multiple sclerosis. There's kind of a catch-22 in performing massage for infectious diseases that have caused neurological conditions, okay? Massage approaches can be supportive and can reduce stress, and that helps control the number of recurrent outbreaks through managing that stress, especially in recurring viral conditions such as herpes. And obviously, standard precautions with any contagious disease. If you haven't taken pathology yet, standard precautions, you will hear about it. That is the bare minimum set of standard cleanliness actions that you need to take when working on a client with potentially infectious diseases, like washing your hands, hand sanitizer, making sure that you have a pump on your lotion and you're not scooping your fingers in it, disinfecting your equipment, changing your linens, etc., etc., etc. At any rate, the person's total stress load is super important with these viral reoccurrences. When a person is immunocompromised to the extent that he or she is susceptible to viral and bacterial disease, the stress load on the body is greater. The practitioner should keep in mind that many forms of massage produce extra stress in a therapeutic sense. So you need to take into consideration the intensity and duration of any therapeutic intervention so that the demand on the body to adapt does not overtax an already stressed system, aggravating the condition. The term less is more philosophy of intervention, which calls for shorter, more frequent interventions, often is indicated. Massage is beneficial for post-polio syndrome as part of an integrative healthcare approach and for things such as herpes. But if you give them an extremely brutal or long duration massage, you're going to stress their body enough that you could actually cause an outbreak rather than being a preventative measure. So another thing that Chapter 5 briefly mentions is neurotransmitter-based disorders. Anxiety states and depression are the two big boys here for sure. All right, depression is one of the more common causes of physical complaints that are actually a manifestation of underlying psychiatric illness. And massage has the effect of increasing the availability of neurotransmitters related to depression, such as serotonin, and may play an important part in the healthcare program for depression. Of course, aerobic exercise is another important component in depression management. And these methods all use the peripheral nervous system as the point of access. Again, massage really affects the parasympathetic nervous system. Massage, of course, is also an effective part of a comprehensive management strategy for dealing with anxiety symptoms. Massage can help with neuropathy. It is not as effective because nerve pain is extremely difficult to manage, depending on the cause of the nerve pain. Again, if there is some sort of entrapment or impingement because of soft tissue, that is definitely something that massage therapy can help manage and offer some therapeutic change for. Otherwise, we're looking for short-term palliative care in these. Another nerve-related or neurotransmitter-related issue that we could talk about is a headache. But headaches are a common symptom of a multitude of things. The brain has no sensory innervation in and of itself, so headaches don't originate in the brain. The pain of the headache is produced by pressure on the sensory nerves, vessels, meninges, or the muscle tendon bone unit in the head. A tension or muscle contraction headache is the most common type. And so for those, you can go to the origin site, such as the trapezius and deep neck muscles at the occipital bone or the frontalis on the frontal bone for any occipital or frontal headaches. Tension headaches usually originate in the temporomandibular joint muscle complex. And connective tissue structures that support the head might be implicated in headache if they're shortened and they pull the head into nerves, creating pain. So also if connective tissues are too loose, they've become lax, they're overstretched, your head's constantly down, you've created like a straight neck or military neck with your vertebral column, and they're no longer supporting the neck and head the way that they're supposed to. Nerve structures may become compressed because of the altered posture. So massage and other forms of soft tissue therapy are effective in treating muscle tension headaches. They won't help a dehydration headache, only water will. But because stress often induces headaches, stress management in all forms is indicated in chronic headache situations, which is where massage therapy comes to play again, because massage therapy helps the parasympathetic nervous system response, rest and digest, and also relax. There is more information that we can certainly dig up. Some of my more successful therapeutic massage stories are from people with chronic migraines that originated in the occipital region. It is impolite to say what some of the compliments were, but let's just say most of them preferred the relief to massage from my massages than any other physical activity that they could be enjoying with other people. Was actually a very common statement that was made. The TMJD stuff, temporomandibular joint disorders that cause headaches, jaw pain, neck pain. You could literally change someone's life by becoming very skilled or specialized in working in these areas. And these are very easy areas for massage therapists who may have physical limitations or joint disorders themselves that don't necessarily want to stand and do a 60-minute massage on someone with Swedish techniques. You can literally sit throughout the massage and work on someone's face. And in this concept, again, less is more in these small areas with nerve impingement. So you're usually looking at treatments that are 2 units. Remember, units are 15 minutes of massage therapy, so you're looking at 30 minutes of massage frequently in these areas. 15 minutes on each joint, maybe 15 minutes on the occipitals if you're going to do a 45-minute. Another 15 minutes for just relaxation on the frontalis muscle perhaps, and on the scalp. So for an hour massage, you're sitting there just working on the face, working around, and it's easy on your body. And it literally is life-changing for someone who is experiencing debilitating pain because of nerve impingements in the head, neck, and face. So that is something to keep in mind. As I have heard from several students that are interested in massage therapy but are a little bit concerned about the physicality of it, there are absolutely specialties that you can get into as a licensed and practicing massage therapist. Even reflexology, you want to work on the hands and the feet and the ears specifically. If you want to learn about doing migraine or TMJD stuff and you have some questions for me, by all means, ask me. Those are some of my favorite type of massages to perform. I am a medical massage practitioner myself. I don't enjoy working at a spa, even though I was a director of one for quite a while. I really like to get in there and perform therapeutic change, or at the very minimum, palliative care for these massage clients. So any questions you may have, I am a massage nerd with these things, and I would love to help you out.